We have Dr. Shirish Varghese here who will be speaking on a very interesting topic of bimanual dissections in proliferative diabetic retinopathy. Dr. Shishir is a consultant at Amita Eye Care in Tiruvalla, Kerala. Over to you, Dr. Shishir. Let's have it. Thank you.
Yeah, thank you, Dr. Avnish, for that kind introduction. So, welcome everybody to this episode 2. So, I'll be talking on bimanual dissection in PDR, and then we'll take up questions from the panel. So, I'm presenting two cases. So, this was case 1, a 52-year-old female, diabetic, recently on insulin, was on Ayurvedic treatment before, decreased vision, right eye since 6 months, vision was counting fingers close to face in the right eye, left eye was 6/6, and both eyes had cortical cataract. And fundus had right eye TRD with membranes till the equator, and left eye also had advanced proliferative diabetic retinopathy. So you can see the fundus picture here. This is the fundus picture of the right eye, extensive membranes with neovascularization. And then in the wide field photography, you can see these membranes which are extending up till the equator with a lot of new vessels and also ischemic vessels which can be seen. So the plan was right eye, vitrectomy under guarded prognosis, left eye PRP3 sittings, and this was, she had cataract also, so she was planned right eye cataract surgery followed by injection Avastin after a week, and then taken up for right eye vitrectomy plus silicone oil injection. So we'll start with so started as a 3-port pars plana vitrectomy. Initially did not put the chandelier, but because did not plan to do a bimanual here. So there was plane at the posterior pole, and we are proceeding from the posterior to the anterior with the cutter. The dissection is going from posterior to the anterior, and now it's almost reaching up to the edge of the membrane there. Now you can see how sticky these membranes are. Each of these is attached with multiple fronds onto the retina all over the place. So it was quite sticky. It won't come with, your rollback dissection or, those kind of dissection techniques. So had to do tandem use of cutter and scissors. So once I reached the periphery, I tried to go from outside back to inside, but it was so sticky that I had to, dissect everything from posterior and then, proceed towards the anterior. So here again, I'm using cutter scissor again. And then now I've finished the inferior membranes. Now I proceed towards the temporal membrane there. So here I managed again to go from posterior to anterior. And now I'm attacking the infra temporal membrane. So with the unimanual dissection, I'm able to complete, remove all the membranes from the temporal as well as the inferior area. And now we proceed towards the superior membrane, which is there. So you can see the superior membrane. I always find it tough, because, to bringing the instruments towards your side, it's very difficult. So I put a chandelier at 6 and then I proceeded for this bimanual dissection. So the right hand is holding the scissor, the left is holding the forceps. And then with the curved scissor facing the retinal surface, I'm trying to cut off all the twigs. Now I've exchanged the instruments. Now the forceps is in the right hand, scissors in the left. And I'm trying to remove all the temporal twigs you can see. So it's causing quite a bit of traction or a pull on the posterior pole as we can see. So I decided to put PFCL bubble onto the posterior pole to stabilize the posterior pole. And then now I'm proceeding from outside in dissection. So sometimes that doesn't work because the membranes are all along the vessels. So then you need to go parallel to the vessel and then trim off all the membrane, maximum whatever you can remove. And once you do that, then you can go from an anterior to the posterior dissection as what you can see here with doing with the scissors, whereas providing counter traction with the max grip forceps, which I'm using here. So there was this thin membrane there in the nasal region, and then while trying to remove that, it was quite adherent, and I created a retinal break there. As you can see, the man got a retinotomy there, accidental retinotomy, while trying to completely remove off that membrane. So as you can see, while I'm proceeding now, again I'm proceeding from anterior to posterior, trying to remove all the vitreous adherent traction from the periphery. And as this surgery proceeds, the view gets quite hazy. So you can see the view is very hazy. So I decided to scrape off the corneal epithelium. Surgery is almost now all heading towards 2 hours. And now proceed to remove whatever membranes are left on the nasal side. And it's quite extensive, heading up almost just till beyond the equator. So I'm holding the vitreous strand there with the max grip and then cutting off all the twigs with the scissors. So I don't like leaving behind any membranes. So to do maximum dissection, whatever I can, I'm trying to do here. And you can see still there is peripheral traction and some peripheral twigs of membranes, which I'm removing with the cutter over there. You can see those. Now the cutter itself is helping me to remove all those small twigs of membranes. So doing cautery there to all the bleeders, and then finally I stain with the BBG, and then proceed to do an ILM peeling under the PFCL, which was already there. So after the ILM peeling, once I don't want any ERM formation later, which is highly likely in this young patient also. And then after under air, I laser all the breaks, whatever I've created with this bimanual dissection, and also do a panretinal photocoagulation. You can see the retina is well attached under air, a sign that there is no traction. And finally, I put silicone oil at the end of the surgery. So this is how it looked post-op under silicone oil. Retina was attached, no significant traction. Also did an SOR after 3 months, retina attached, and she gained 624 vision. So now we go to our case 2, which was a 70-year-old male, diabetic hypertensive on insulin, decreased vision both eyes since 1 year. Vision was right eye was hand movements, left eye PL. So basically nil-eyed. So here I chose to operate the better eye. He had cataract also, and the fundus showed right eye tabletop tractional retinal detachment, and left eye had a chronic TRD. So you can see the TRD here in the right eye. It looks like a lump, mass kind of lesion, and left eye was quite extensive. When you see the B scan there, you can see the right eye B scan looks large lesion with a TRD we can see on the B scan, and left eye is like a chronic detachment there, almost like a closed funnel. So here we plan to do the right eye surgery. Again, same very GVP, cataract followed by injection and then vitrectomy. So started off with the 3-port. So that's how it looks intraoperatively, a very vascular lesion. This is even after giving Avastin and then waiting for a week. So here finding the plane was the main thing which I managed to do with the cutter there. A little bit posterior plane I got, and then I'm trying to, whatever twig I can, I'm trying to remove, and then I'm proceeding from posterior to anterior and then inducing the PVD. So while doing that, here the retina was so ischemic. Here again, I had a small break. I'll just rewind that, and small break. What you can see there, happened while trying to induce. So now again inducing from anterior and then coming towards the posterior part. Now, while doing this maneuver, I know that I cannot proceed beyond this point, and that's when I switch over to bimanual dissection here. So I hold again the twig, and then I proceed from posterior. So now I'm going from temporal part towards the nasal part, trying to remove all the, while holding that fibrovascular proliferation, what you see. You can see the break also there, which has happened. So here again, bimanual dissection with the scissors, removing all the twigs there. And as I slowly proceed, I also do a gentle blunt dissection with the scissors. So holding and then going underneath the prolif, removing all the vitreous traction and then cutting with scissors. So this goes on for some time, and then finally managed to see the macula, at least could see the macula now. And then with the cutter itself, managed to trim off that prolif. Now you can see it's free of all the attachments in the posterior pole. I know the macula is safe. And then with the cutter itself, uh, remove this whole fibrotic, or this whole proliferative lesion, what you see. So removed all that, and then there were quite a bit of bleeders. So here I'm trying to cauterize the bleeders, and after that I have put PFCL on the posterior pole, and then induce PVD, finish off this PVD induction in the periphery there. You can see the retina is bullous. So unfortunately under PFCL, there were some bleeders which were still left, and under PFCL he bled. So I removed it and re-put PFCL after staining, and then removed off all these clots and peeled off the ILM internal limiting membrane also. Did ILM peeling in this case. And then finally under you know using through the same break, I did a fluid air exchange, drained off, and then did a fluid air exchange, and then followed by silicone oil injection. But however, there were still clots at the posterior pole. So luckily all the clots resolved. This is a picture under oil. Now his vision improved to CF 1 meter, and then post-operatively 1 year down the line, he has 660 vision, and this is how it looks without the oil. So that brings us to the end of both the cases. So we have with us, now we go on to the panel discussion. So we have with us our moderators, Dr. Chittaranjan from Trilochan Netralaya, is a vitreoretinal surgeon, Dr. Mohit Dogra from PGI Chandigarh, and we have Dr. Divyansh Mishra from Shankarai Hospital, Bangalore. So since we are discussing this case of, this is also be beneficial for the beginners too. So let's start with the first question to Dr. Chittaranjan. So which cases in PDR you think would require a bimanual dissection? And like basically trying to emphasize on how would you look when you look at a case externally, how would you decide that this case will go for a bimanual surgery?
Good. Thanks, Cecil. First of all, very great surgeries, very nice, beautiful surgeries. And answering your question actually starts with your surgeries only. The common thing in both the surgeries, these are complex cases with very firm attachments. So this is the number one indication for choosing a bimanual surgery, because many people may say that in the advent of this port optimization and 10,000 cut rate with the tip of the cutter being towards the end of the cutter, we may escape in almost all cases without bimanual need of a chandelier system, but it's not true. So in cases like complex cases with very firm attachments and something like OCT, what you are showing over here, OCT is a very commonly performed thing, but one unsung hero in this investigational thing is ultrasound base scan. So when we have the thick membrane kind of thing, what you showed in your picture, like a very close funnel kind of picture, or sometimes there is a H-shaped attachment, because if the attachment of the vitreous towards the retina is very broad, then it becomes a H instead of an X, which is a focal attachment. Focal attachment we may escape, but H-shaped attachment. So that's why in the preoperative workup, B-scan is a very important thing. And another thing is clinically, if we are seeing very thinned out retina with a thick membrane, there is very a chance of creating iatrogenic retinotomy. So we should be careful. We should be prepared with bimanual thing. And to sum up, strongly adherent membranes, those are difficult to be dissected unimanually. In those cases, we should be ready with our bimanual chandelier system. Yeah, this is the answer to your question,
Oh,
Cecil.
yeah. Thank you. So basically a B scan and to assess the whether TRD and all that is there, and also to see the type of membrane, what you can see preoperatively. So we go on to our next question to Dr. Mohit. So what are the preoperative requirements one must consider before planning a bimanual surgery, and including timing of preoperative anti-VEGF? Which cases will you decide when to time the anti-VEGF injection before the surgery?
Yeah, thanks, Shishir. And I second Chittaranjan that, terrific surgeries, both of them. I
Thank
think
you.
as far as the pre-operative requirements, we discussed the patient factors and patient, stabilization in the previous webinar. So I'm going to
Yes.
not at the count, I don't want to sound repetitive, so I'm not going to go into that. I look at two things. I think what's important and what must be, depending on how frequently or how commonly one tends to do bimanual surgery in their setup. If it's something that one tends to do a bit infrequently, I think it's important to ensure before this case is begun that these cases, depending on how your list is, are the earlier or the first cases in the day. You need to be fresh. As you said, and you briefly mentioned in your first case, these are long cases. They require more than your due, time and patience. And the later in the day that they tend to be posted. Let's say if you've already done a few cases, or you're a bit tired, or you've had a OPD, that might not be the best time for them. That is one. I think the second is also the equipment must be ready. Your staff and you and whoever assisting, they must be on the same page that yes, a chandelier might be required. Your non-tooth forceps and the other instrumentation, which we'll come to maybe later, must be ready. They mustn't think that if 90-95% of the PDRs that one tends to operate are non-bimanual, then all of that equipment is not ready at that point in time. As far as a pre-op anti-VEGF is concerned, I would almost say that if there is if looking at the factors that Chitranjan mentioned, that if some of those are there and there is a very strong suspicion in your mind that you will need bimanual surgery, I would give pre-op anti-VEGF in all. I think if you need bimanual surgery, means the disease is more advanced than a regular TRD, or it's a combined retinal detachment. Lots of times they are single-eyed patients. I would, at the cost of, I am okay to have a bit of a crunch phenomenon in these patients, since most of these eyes will in any event end up getting oil. But what I don't want is a ton of blood at the back of the eye, which I cannot try and control and get clots. As far as the timing is concerned, I would say anywhere between 3 days to 7 days, depending on where you're at. I think your second case, which you showed, which was more vascular, I would tend to look at the upper limit, which is about 5 days for me. The first case, I'd look at about 3 days. But a combined retinal detachment, I want avascularity, and I don't and I'm not concerned about a crunch because in any event, there is a break. Really bad TRDs in which oil is something I'm planning to go with at in the beginning. A crunch happening is much lower down on the list. So definitely pre-op anti-VEGF, minimum 3 days for me, going up to 7 days, depending on how vascular it is.
Yeah. Yes, great. So yeah, so the regarding the first thing what you said, that is also quite important. You have to post less cases on that day because you need to be fresh when you operate these cases. And the second thing also regarding the anti-VEGF, you need to give the maximum amount of time for all the vascularity to reduce. So we go on to our third question. So what are the instrumentation one must have in hand? 23 versus 25 gauge required for bimanual dissection. And what are the light source choices and placement for Chandelier? So we put this question for all the people who are starting out or all the surgeons who are starting out bimanual and even the beginners, an introduction to bimanual. And this question is for Dr. Divyansh, and he'll also be showing us some interesting presentations. Over to you, Dr. Divyansh. After you answer, then we can share your this thing.
Presentation. Okay, sure.
Yeah.
Sushil, you have a very nice presentation, elegantly done surgeries. The duration, whatever you have edited, obviously you have done the hard work of editing, but it may have lasted for more than 2 to 3 hours.
Yes,
Hard
yes.
work is seen over there, and you can see the post-op retina being well settled. So what instrumentation, the question which is asked to me, whether it is 23 or 25, my answer is anything would work. Yes, I don't want to take names because there is finally how you are tackling or how you are attacking the membrane. It doesn't matter as to what instrumentation you're having. It's not that the 23 is going to perform inferior to the 25 gauge or to the newer equipments, but yes, you have a little additional edge, I would say, because of the port optimization or port being very close to the edge of the cutter, and the newer cutters where it is like a beveled cutter. But everything comes with its plus and minuses. So I have been operating on 23 for years together, and I did, because of the certain machines which we have. But it's again to say, so it's how you are tackling a membrane. It's not the cutter, it's not the machine, and it's not the instrument. It's how you are tackling a membrane. So how to tackle a membrane is to identify the vantage point. So what is the vantage point? Is the point where the membrane and the bare retina is seen. As you could see in some of the initial part of the videos, what Dr. Shishir was presenting was that he was able to go from inside out and then go on till the periphery. But very important part was to identify the vantage point, that there is no membrane or no extra, what to say, as chytic vitreous or secondary membranes, which we usually call this in diabetes, are there. Light sources, choice and placement. So the important part would be that if there is an option that you have a bright light source, because for a bimanual surgery, this it's like a chandelier which is hung on the top of the wall. So usually chandeliers are low lit lights, so they're not very brightly lit lights. But as a VR surgeon, it has to be bright because the light has to come to a point of focus where you want to operate. And very important as to placement. So if you are placing it superior, you would be able to achieve a good illumination inferior. So it's exactly opposite. You can do it superior, but there has to be an assistant who directs the light and keeps it when you want it in that ways. Otherwise, there are options for even like a dual chandelier, or sometimes you can have an option for three chandeliers also, which very rarely in a very advanced disease where you are going by manual and the light is not enough, cornea is hazy and things like that, and you have already operated for 2 hours and corneal edema has started to come into play. So that's why, so placement is mostly, I would say, I have put superior. Very rarely I have put inferior. If I see, like as what in Sashir's case was, always the difficult part would be the superionasal or superiotemporal, depending if you're a right-hander or a left-hander, because of the achievement of the angulation of all the instruments. As we could see that Dr. Shishir was finding it difficult
to get a plane and operate in such a way that your retina and the forceps and scissors are not crossing each other. So always the superior nasal for the right handers, and for the left handers it would be exactly the opposite. So uh, very difficult choice, but it's, I would again say that how you are attacking a membrane is more important, and where you are attacking, that would help you understand both the, not only gauges, not only the armamentarium, but also the placement also. So should I finish my presentation or we do it later, Shishir?
No, we can show do the presentation. I'll just stop the share.
Sure. So,
Yeah.
okay, so yeah. So again, so this is if there is no chandelier, or if for some reason chandeliers are out of stock, or you do not have an option for a chandelier, or all the chandeliers are unsterile, or for whatever reason there is no availability, or whether you have not bought a new chandelier. So in this, what you can do is to repurpose your old light pipe fiber, and where it means, like in this case, as you can see, the plastic handle. So this is one of the systems which we are working on, but you can also have different light sources. But finally, the basics is the same. You can cut through that, and then you would be able to get like a naked fiber, and that itself can be used. How exactly you would want to hold that light fiber into place is, you can use either a 42 gauge buckle, or a 240, or whichever. You can even use the plastic tubing of your, because we usually use that IV tubings to hold the sharp instrument. So you can use even one part of that also. And then once you connect it to the light, it works as well. So how does it work? So this is a 23 gauge chandelier which we had created. So you can do it for 25 also, it doesn't matter. As you can see, in this case, we had 240. In this case, we had already put a BB, and then we wanted this part of the 240 was available. So we had passed a 24 gauge needle, and then you have to pass the light through that, and then the chandelier is available for utilization. And the same way you can use it for a 25 gauge also. And how does it look inside the surgery? So this was a redetachment with a PVR where we had put a BB. So in this case, we are means, as you can see, directing the light actually where it is required. And as you were discussing, it's the multiple instruments which can be used in alteration. So in this case, the forceps is used to create a traction, and the cutter is used like a scissors, where we have a very controlled kind of an action of cutter in this case. And the next thing, so usually I would advise all the beginners to put the chandelier as a second port, not as the third or the fourth port. Why? Because the eye may become very soft, because already there are two ports which are made. And in this case, as we were discussing, is to identify the vintage point. So what we are able to identify over here is the edge of the membrane, or the secondary membrane, which is below the primary membrane and which extends much further away, so that we have a good space to work on. Sometimes you can use scissors in a closed fashion and go and do a blunt dissection. And when you're coming back, you can open the scissors like how we do it for the kind of tenotomy. So it's a little traumatic, but yes, obviously you need to keep seeing always the edge of the scissors. And one more thing, what I'm doing right now is utilizing the flute in one hand, because there is a bleeder, and which is exactly below the fibrous membrane, which is very vascular, as you can see. So you can utilize the cautery and then utilize it. Because what I'm using a 25 gauge cautery, it's, as it is very sharp, so small membranes can also be dissected. So you need to always see as to how the dynamic adhesion is there between the membrane and that particular issue, or that particular space. So as in this case, I'm using a cutter and a cautery simultaneously. Why I'm using a cutter to remove the blood? Because cutter is a side port and fluid is an end-on port. In a detached retina, if you try to use the fluid, most of the times you would create an hydrogenic break or retinotomy, because of the fluid getting directly aspirated, or the retina getting aspirated into the fluid. So that's why the side on, and you have a very good control over the cutting. And then these are like freshly highly vascular bleeds which are occurring, so you can actually identify them correctly. And you can avoid even the cauterization bubbles, the bubbles which get created by the cautery, which get deposited onto the posterior lens surface, being it pseudophakic or phakic, it doesn't matter. So that also helps. So you can simultaneously keep sucking it. And in this case, what we are doing is not trying to remove the clot, but to aggregate it so that we get the clot at one particular point and then allow the clot to be stabilized. So in this case, there was a vascular membrane. So I'm trying to cauterize only the edges and then trying to see if I'm able to get the nudge and then finish it. So this is at the end where I'm able to finish the whole dissection. So these are all the points which I wanted to discuss, but yes, there are like it's different ways to skin a cat. So there would be many more ways. Other colleagues would be able to help us better. But bimanual surgery is all about how to do it and when to do it. So thanks, Sashir again.
Yeah, thank you, Dr. Divyansh. So one small question regarding that chandelier. How do you, I mean, it stays in place, because you're putting the sleeve. How do you make sure it stays in place in this thing?
So yeah, Shish is a
In your
very
port?
correct question, because in this case there is no glue which is holding it back from either going in or coming out. So what we do
Yeah.
right now is use two kind of sleeves, so that increases the resistance of it getting prolapsed inside. Uh, but out of the scenario, I just want to give you an understanding as to, as you were discussing right now, to imagine chandelier is hanging on the top of the eye wall, and to get the illumination till your operating space, it's much lesser. So if it's a pseudophakic patient, I sometimes ask my colleagues to even push it inside so that it becomes like an extra light pipe hanging over there. But in a phakic patient, yes, the issues of touching the lens or getting into the
It's,
retina also is there. But as I told you, using two kind of stoppers avoid that slippage as often.
yeah, great. Thank you. There was a question in the chat box. How to identify second membranes? You already mentioned that in your video, but once again for the viewers,
So
if you can
very
just tell.
important to
Yeah.
understand as to what the secondary membrane is. It's a membrane or a vitreoskytic membrane, which actually, so if Shishir can go back to his OCT, which he was showing once, or if not, then I would present and just show you
Yeah.
as the OCT what the secondary membrane is. So I think the OCT is not as great. Shishir, shall I just
Yeah.
share again, just to explain?
Yeah. Yeah. Sure.
Okay. So because that part I had hidden it because so if we, okay, I have to unhide it. Yeah. So if we can see over here, there is one membrane which is holding the retina taut and going into the vitreous cavity, but there are multiple skytic membranes which are going onto the retina and far beyond it. And if we can see, not only on the nasal side, but on the temporal also, there is one fine line which is extending even beyond. So this is the secondary membrane, the one which you are seeing from the top. If to see, it is passing from exactly over the horizontal part, where temporally you can see this kind of a whitish band and this frond of all abnormal blood vessels. This is what you're seeing from the top. But actually, the membrane is below here. So this is the secondary membrane, or I would say on the retina, which is just abutting it. So you need to use any sharp instrument. You can utilize even your needle, as in our case, we were using 24 gauge needle because I used a 23 system. But in a 25, you can use a 26 gauge needle, or a membrane pick can also be used, so that we nudge that and you would be actually seeing that the membrane extends far beyond. And then once you come and take it close to the primary membrane, then you would be able to see the vasculatures also very clearly, and their kind of attachments to the vitreous and vascular arcades, and you would be able to manage much better. But obviously these are tricks and trades, as for each surgeon there are multiple other ways to also identify. Sure.
Yeah. Thank you. Thank you, Dr. Divyansh. So we go on to a fourth question. So intraoperatively, when would you consider a case, for bimanual surgery? And when do you think that this case can be tackled bimanually? So this question is for Dr. Chitranjan. So why I'm asking this question is because a lot of cases you start doing, nicely, but then you end up with a break, and then you're forced to convert to bimanual. So at what point in time you realize, I should stop before I could create a break and I should start, bimanual surgery?
So yes, thanks, Cecil, again. So we should always be ready for the plan B, that is bimanual surgery. Even if we have not a very good chandelier ready with us, Divyans has already told about his innovation. So we can always make and go. So the situations are very tightly adherent fibrovascular membranes, in your case and the Diban's case, where during surgery we end up in iatrogenic retinotomy breaks over there, and those cases we need not continue with unimanually because that will just extend the break and extend the RD. So in those cases, we should convert to bimanual thing. Second is the presence of a combined detachment that if we would have detected preoperatively, okay, but sometimes there is a surprise also. We thought it is TRD, but there is a small break and you think you would identify it is a combined retinal detachment. In those cases, it's better to go for that. And of course, PFCL will be needed as you shown in your first case. So combined detachment cases we should go. Another thing is when we have bleeding, extensive bleeding is there. In those cases, if we use a Chandelier, we have both the hands. We can use diathermy or anything like a cautery to manage the bleeder. So that is one of the indications. And another extended indication will be when we are not able to identify the planes properly. Like you showed in your case, you are doing great surgery, but there is every chance of injuring the retina because it is very firmly adherent, that membrane. So if we are not able to identify and we are not able to do the surgery to dissect the membrane, it's always better to change to bimanual thing and do the dissection with both our hands. So these will be the indications when we should change intraoperatively to bimanual.
Great. Yeah. Thank you, Dr. Chittaranjan. So we move on to our fifth question for again Dr. Divyansh. So you already showed one technique where you're using the pick needle to induce the PVD. So here again I'm asking that same for our viewers. So what technique would you use to induce PVD and enter the correct plane? So you use the pick. Any other technique would you feel you can use other than the pick?
So to say about PVD induction in the I think the second case where the peripheral PVD was a big issue, how to manage those cases would be very different from a case like in this where you have a space or a separation on the posterior pole. So you can actually use a visco injection also to create a posterior vitreous detachment. But mind you, two important things. One, your infusion should or because we use gravity assisted infusion, but if you are using infusion which is either machine driven or has IOP compensation, better is to decrease the pressure, because as soon as you are injecting, the intraocular volume is increasing. So if you are injecting visco and you are not decreasing the pressure, you are actually going to create a very taut interface between the retina and the membrane, and where it can cause tears just because of your injection of the visco itself. There are different techniques to inject visco. You can either use a needle at 24 or 26 gauge because it has a beveled edge so that you will be able to go in between the membranes. But there are certain authors which have even utilized the reflux mode in one of the very specific machines. Obviously, I am not taking any names for that, where you can aspirate the visco into it, and then with the slow gradual reflux, you can actually keep injecting the visco. Mind you, we need to be always careful in injecting visco, because visco is so again the question would be what kind of visco, whether it is dispersive or cohesive. I think that question probably we can take it later. But whichever visco you are opting for, the answer would be that inject as slow as possible and keep seeing if there are very dense attachments of retina and the membrane, so that those pillars, if you are disrupting rapidly, you may create breaks, and if it is close to a blood vessel, it may bleed and even go into the subretinal space. Similar kind of visco injection in the periphery beyond equator is not possible, so only posterior pole it is okay. The periphery ones, I would better advise, like I was writing in the comments also, that if you feel that the vitreous is not getting detached beyond the equator, best way is to truncate the vitreous from the posterior membranes and leave it. If you still feel that there are membranes or breaks which are happening in the periphery, adding a belt buckle. And in certain cases, I would still think of putting a solid silicone, and if required, a suture also in those cases. So probably the discussion can be taken with other of my colleagues also.
Yeah, so Dr. Chittaranjan, Dr. Mohit, what would be your technique of PVD induction?
Mohit first. Mohit.
Yeah, thanks.
Yeah.
So I think most points very well covered by Divyansh, and also we I think touched on this briefly in the first round. I think depends on where the bulk of the membranes are, right? It could just be it could be a tabletop TRD. It could be almost like, yeah, as you referred in your second case, like a closed kind of a funnel kind of an TRD, like in your second case. Now in the first case, if there's a flat, if the height is less, if the membrane is flat and it's relatively translucent, which is what your first case was, so you could see a lot of the underlying retina, and the membrane didn't have a height. It was flat and it was like a very low lying, almost like a Japanese or a Korean sit down dinner, which is low, right? Now that is now those cases there's an issue. In those cases, you might need to attack it from different sides. You might want to first try and do a mini PVD at the disc and then try and look at what's happening. If you can get an opening, as you were able to get just with the cutter, and then switch on and go to bimanual. So you don't need to start bimanual in those cases which are low lying with a lot of translucent membrane. The second one, which is the one which was, I believe, a more tougher case, which if you were to discuss in ROP circles, they would actually call a blister-like ROP. That's exactly what they call it, right? Except in ROP, it's poorly developed retina. Now there, I think it's important to begin bimanually. The second patient was almost crying out if you were to operate to begin bimanually, because you could see the physically occluded vessels, and there was absolutely no way that a cutter could have gone in through the so-called closed roof. So you had to go through the edge, try and find a membrane, and with those occluded vessels, there you actually had to, start with bimanual dissection. So in that patient, I would I would start superiorly. I would start, anterior to posterior, and then try and look at what's happening. If you can open it up, great. Otherwise, I would take a second go. Inferiorly, I would start again anterior to posterior, and then try and get a kind of an edge. But mini PVD, if the membranes are low and flat, and if it's very opaque, and if it's elevated like the second case, I would go to bimanual straight away and try and approach it from different sides and try and get an opening one where, and then kind of go to the other.
I
Yeah,
agree
Dr.
with both Dibyans
Yeah.
and Mohit. Just I'll add one more thing, that there are two concepts. One is inside out and one is outside in technique. So all of us, we have seen over here inside out technique, and the surgery has come very well. But the only disadvantage is that it leads to bleeding. And during diabetic vitrectomy, we try to get the bleeding as late as possible in the surgery. So in that case, what my preferred thing is that from outside in, if I try to induce the PVD somehow and get the plane over there, and I try to dissect it like till there is no further bleeding and all. And if there is by chance some tear is there, iatrogenic tear is there, I try to take the kind of opposite side, just like in Rexis when there is extension, we try to take it to the opposite way. I to take in that way. Just to addition to that, rest of the things Mohit and Dibyans have told. I agree with them.
Yeah, great. Thank you. So next question to Dr. Mohit. Now, like you saw in the first case, you suddenly it's like a surprise. You go in and there's membranes everywhere. So if membranes are all around, where would you initiate your dissection first? Like as a beginner, I go in and see, and there's inferior, there is superior, there is nasal, there's temporal, all around 360 membranes. So what do I do instead of panicking? Where do I start systematically?
Yeah, I think great and important question. Part of it I think answered in the previous one also, but I'll just
Yes,
repeat one more
yes,
time
yes.
that if you can visualize the underlying retina, which means that the fibrovascular proliferation is not super opaque, then I think you can begin unimanually. You can begin as you would do a unimanual case, maybe try and do like a mini PVD, at the disc. You can try and do that and try and approach it from there. And if you can get a plane, then once you get to the, let's say the terminal part, the more peripheral that you can get, you might need to convert to bimanual, right? However, if it's the second case, which is again very opaque and it's high and it's a posterior high and opaque membrane, there you need to go bimanual straight away. And as Chitranjan also rightly mentioned, in that, although like your second case, you cannot go inside out, it has to be outside in, because that entire closed kind of thing, you don't know what's the macula could be right at the top. So you could just,
Top.
your
Yes.
first
Yes.
nick, if you want
Yes.
to try and go inside out, could be the end of the story. You can have the optic disc right inside that sometimes. So in those, if it's
Yes.
opaque and you can't see, you want to go, outside in, and that's where you want to begin, and you want to try and shift to bimanual early. The moment the thought of bimanual crosses your mind कि इसमें शायद bimanual कर लेते हैं, that means you go to bimanual. It's generally half a minute.
Yes.
It's as the cataract surgeons would would say, the moment the thought crosses their mind that we should try and get iris hooks, and they don't, because they tend to feel कि नहीं हो जाएगा is the time that it tends to form an issue. You will never repent converting a case to bimanual because it's overkill, as
Yes.
some might say, but you might repent sometimes, or in fact, a lot of times, if you're doing as complex cases as these, if you do not go to bimanual in time. So, lower threshold for bimanual cases like case number two, bimanual straight away. Cases like case one, you try and make an opening exactly similar to what Shishir did, try and get to the periphery as much as possible. And then when you feel, it's not coming out, then you go to bimanual.
Man. Yeah. Yeah, Dr. Divyansh.
Divyansh.
So I have a little different take from this because if you have seen a videos which have chandelier illumination, the videos would be much brighter and better recorded. So if, as for me, if I see a patient which may require a bimanual, I would start with bimanual. There is only one thing that I have to remove the bimanual port at the end of the surgery, even if I'm putting gas or air or for whatever tamponade which is required. But the problem is once you've done a vitrectomy, then putting a bimanual comes with its own problems that the eye would become very hypotenuse, and then putting a port itself would be very, very difficult at that point. So my take would be one extra step, but yes, it would help you not only having very good surgical videos, but also help you, if required, to peel the membrane. You already have the port in place. If not, at the end of the surgery, you just remove it when you are starting your fluid exchange. So that's my take on it.
Okay. So we go to the next question, and this would be to Dr. Chitranjan. What would you do if membranes extend beyond the equator? So three options: leave it. I would not leave anything behind. It depends on the situation. And then there was a discussion in the chat box also whether to add a buckle or not. That'll be the fourth
See,
option.
yeah, see, I will not leave it definitely. But honestly saying, buckle for these kind of cases, my threshold will be very high. That means I tend rarely, very less frequently to use buckle in these cases. And as I told, the outside in technique that actually helps me in tackling these kind of membranes over there. And if I have PFCL in the posterior pole, I have stabilized the posterior pole disc macula and the arcades, everything. And I can be, safely removing the membranes. But yes, we should not be very complacent. Sometimes what happens, there is with the vitreous, there is attached retina, and okay, when we're doing the periphery, we become little lax and we tend to create the retinotomy over there. So same cautiousness, same seriousness, removing the membranes, and maybe buckles. My other colleagues they may say, but I tend to less frequently use buckle in those cases. Yeah, that's what I'll say. And just to add, as I told Shisel, like while removing those membranes, if suppose there is a tear, don't continue in the same go because that will extend the tear only. So try to go in the other direction. And actually, many times, you will escape with a small tear only. Yeah. Maybe others can add to this, Mohit and Divyans.
Yeah. Dr. Mohit.
No, I mean, I'm actually okay, and I also mentioned that in the chat. I'm actually okay to
Yeah.
leave membranes in the nasal periphery for two reasons.
Yeah.
It's akin to, and I'll draw the analogy of FEVR. right? FEVR or falciform fold secondary to congenital etiologies, let's say toxocara or you have membranes. You tend to remove some of them. You just go to the edge. Sometimes you can't even get it beyond the macula, and you trim it and you leave it. Right. And I understand here we're looking at, there are breaks happening, but if nasally the retina, the eye is very forgiving. Yes, you cannot leave sprigs everywhere. It can't be, like a island inferior to the equator is inferiorly, island just superior to the superior arcade, island nasally. So that's not going to happen. And that's not going to work. Yes, you want to try and get everything done. But I think Divyansh alluded to that a bit, earlier. Upper nasal is notoriously difficult depending on the eye and the preference of right or left hand of the surgeon, as can be upper temporal. Upper temporal, I think, needs to be removed no matter what, because that's where a lot of the retina tends to be. I think nasally, if you're about 4 disc diameters, I'd say, which is about a little bit posterior to the equator, anything beyond that, I'm very happy to leave. Retina is thin. I'm struggling to get there, and it's not going to do anything. And even if it does, lasered, all of the hyaloid removed, there is a lot of real estate between that left fibrovascular proliferation and the disc, with a lot of rows of laser to try and stop anything coming, towards the macula. So I'm okay to leave stuff in the nasal part.
Nasal pen. Okay, great.
So
So that was a
I
Dr.
need not
Divyansh, you
be-
want to say? Yeah.
Yeah, sure. I need not be reiterating as my other colleagues have suggested, but if we think of a patient who has not had detachment and is presenting to us with a fibrous proliferation on the nasal side, we would avoid that area and do laser at other places and leave it. So the only thing which we need to work about is whether the traction is getting transmitted to the macula, disc, or superior and inferior arcade. Rest of the things really means visually are not. It's as a surgeon, yes, I want everything to be out, but for that matter, I need to be careful that I'm not creating an extra break. So that's would be my take and a short answer on that.
Great. Thank you. So we come to the last question to Dr. Mohit. So preoperatively, when would you choose not to operate? So that's, how does a VR surgeon decide that, instead of doing some stunts, when not to operate?
Yeah, I think very, very important, Shishir. In fact, honestly, I'd say that maybe a reflection of me working in a tertiary care government institute up north. But I think I'd have a 50-50%, that to a lot of the bad diabetic TRDs that we get. I think half of them I refuse and half I operate. Honestly, that's honest admission. But I think a few things which I think most people would know. I think if you have florid NVI and large angry vessels, not just at the pupillary margin, but all the way across the iris, and sometimes you can actually see along with ectropion. If you have ectropion and large NVI, I think the quantum of ischemia back there, you might be able to regress them with anti-VEGF and get a window of opportunity to try and operate. But that is almost, so ectropion tells you there is fibrosis also which is set in. So there's a reason ectropion is happening, because because the angle is also gone, and that's what's happened. So ectropion NVI, I'd say don't operate. The other thing is, if you're giving an anti-VEGF, I think it's very important to get fitness beforehand. Please don't run into these patients and thinking कि कुछ नहीं होता, हम कर देंगे, cardiac issue भी हम ठीक कर लेंगे. Please get ensure that the anticoagulants, not your clopidogrel, ideally, and not your aspirin. If you can, great, but definitely your anticoagulant. If the patient is on warfarin or the direct acting anticoagulant, which are more common now, they are off those drugs prior to surgery. If they are not tackling these surgeries for 2-3+ hours, is going to land you in a lot of trouble. It's heartbreaking at the end. It's backbreaking with absolutely confidence shattering also. The other thing is, the cases that you showed were tough cases. The case number 2 that you showed, Shishir, you're experienced expert surgeon. I'd say a lot of people, even if you know what to do, it might be operable in your hands, might not be operable in everybody's hands. If you're starting out and it's something that you haven't done, if you've only been doing fractional retinal detachments in which, let's say, the vision pre-op was count fingers close to face or half meter, 1 meter, please do not try and operate cases like case number 2 to begin with, or even when you're in the initial part, because mind you, that was the better eye.
Yes.
That person does not have a second bite at the cherry. So there might be someone, and I'm sure everybody knows there might be someone with a better skill set out there who might be able to do a better justice to that case. So it's important to say no. If you in your heart of heart and in your mind feel that what, I don't think I can do this, and everybody has their own threshold for that. I think the other thing is what one must understand, and we spoke about this. So if it's a very flat membrane and you can see almost all of the retina, so it's a very thin, translucent membrane, but it's all over. Those are generally really terrible news. Generally, the
Yes.
opaque high ones look bad. Pre-op vision is terrible, but you're able to get the retina back. Functional outcome, separate story. But the ones which are
Yes.
really thin and flat are not great news. They take a lot of time. That means there is absolutely no PVD which has happened. It's stuck all around. You'll
Yes.
take 4 hours, and whatever little retinal ganglion cells are left will be destroyed during surgery because you're going to get your bottle height up multiple times. So those are some that I wouldn't
Yes.
operate.
Great. So we almost it's 8:50. I mean 9:50 now. We come to the end of the this thing session. We had a great discussion. So I'll just briefly summarize from question 1 to 8. So preoperative assessment extremely important. You need to know whether attachments of the membranes are firm in these cases. So B scan OCT very important to identify even your whether the CRD is there, or even your secondary membranes. And preoperative factors, Dr. Mohit mentioned, other whatever he had mentioned in the Webisode 1. So along with that, you need to plan your OT day accordingly when you're posting such type of cases. Post less on those days, and you should operate when you're extremely fresh. So next, Dr. Divyansh talked about the gauge, and also his do-it-yourself chandelier. And he was also suggesting that most of these PDR cases, especially the complex ones, you put off all the 4 ports itself, in the beginning, so in case if conversion to bimanual is required. And then he also spoke about the vantage point. Where would you identify your plane, and find the second membrane, and start your dissection from there. And intraoperatively, how do you know when to convert to bimanual? Dr. Chitranjan spoke about it. So tightly adherent FPs, before you have your retinotomy, before that you need to plan and convert the patient to a bimanual surgery, use PFCL, control the bleeding, etc. And also we talked about the different types of PVD induction, visco dissection, and Dr. Divyansh also showed with the needle how he had induced the PVD from the periphery. And also in large cases, what Dr. Mohit mentioned, start from the anterior part of the membrane, not from right at the center. And when not to operate, extremely important. Difficult cases, one-eyed patients having only CF 1 meter vision, and extensive membranes up till all the aura, where there is no PVD, always better to leave them with that vision and just follow those patients up. So thank you all the moderators, and also our core group. So I would like to all the viewers to subscribe to our YouTube channel as well as to our Instagram channel. We'll be all the summary and the snippets will be slowly posting on the Instagram channel. I'd also like to invite everybody for our Webisode 3, which will be on the 17th December 2025. It's on a Wednesday, and we will be talking on macular holes and macular hole surgery that time. Thank you. Over to you, Dr. Avnish.
Yeah, thank you, Dr. Shishir. And I think we had a very good discussion on navigating through bimanually in PDRs. So until next time, thank you, everyone. Thank you for being a part of it. Thank you so much.
Thank you.
Thank you. Thank you.
Thank you, everyone. Thank you.
Good night,
Thank
guys.
you.
Thank you.
Thank you.
Bye.
Night.